My name's Justin Brophy. This is a presentation on rheumatic fever. So rheumatic fever, which can also be called acute rheumatic fever, is an autoimmune disorder, and it's characterized by essentially your T cells and B cells primarily having autoimmune function, and as well as your innate and your adaptive overproducing cytokines. That's going to create the characteristic fever from where it gets its name. Then you're also going to get joint swelling and heart complications. And heart complications, we'll talk about, are the most important for this disease. So it's not something that you just have or get. It's actually a combination of a genetic predisposition and an untreated pharyngeal group A streptococcus infection. So before we get into that, I'm going to go over some incidence. So it's actually hard to predict exactly what the incidence is, and that's for a couple of reasons. But this is the CDC's numbers, and they believe that there are about 500,000 new cases of rheumatic fever every year, and that of those living with rheumatic fever, about 250,000 every year progress to the point where it's actually categorized as rheumatic heart disease. So they say about 300 million people living with that rheumatic heart disease, and about 300,000 of those people die every year. So uh, those are pretty decent numbers. There's a decent amount of morbidity and mortality. This obviously shows also that the main concern for rheumatic fever is whether it's going to progress into rheumatic heart disease, because that's where the real mortality, as well as the kind of burden on healthcare systems, is going to come from. But interestingly enough, rheumatic fever actually starts at a very young age. It's most prevalent between 5 and 14. And the next slide will show some of that. But before we get into that, the difficulty for predicting the incidence comes kind of twofold. Because it's so prevalent in that very small age group of about 9 years, 5 to 14, it's hard to get a model that accurately extrapolates that onto the rest of your population. So poor modeling is going to mean a big error in population estimate. Then the second reason is that there are certain areas that we just have really poor data on. And again, it's hard to kind of extrapolate our data to those areas like Africa and Asia. Especially Africa, there's a lot of kind of lower income areas that we don't have data on, and specifically rheumatic fever is much more prevalent in those areas. So you can't just take what we know from the amount of people in the US or in developed countries that get rheumatic fever and put that onto a developing country. So again, incomplete data and poor modeling are going to kind of make those numbers a little more rough. So here's a list of the prevalence, and this is just 5 to 14-year-olds. And this is a study from 2018, but it's a review, so it's looking back as far as 2009 and taking data from other studies. And what we find here is, although we have a really large difference in the annual cases per 100,000, what the study said and what this sort of averages out to is anywhere between 8 to about 51 cases per 100,000, and that's just of the children 5 to 14. But that's your expected numbers, 8 to 51 out of 100,000. So now we have pathogenesis. So this is caused obviously by a genetic predisposition, and then when you have that predisposition and you have a pharyngeal group A strep infection, there is an antigen specifically of that group A strep, protein M, and that protein M contains epitopes which are really, really similar to some of the epitopes on proteins in the human body. So if you have a genetic predisposition, what will happen is you will get an overreaction starting with this monocyte overproduction of TNF alpha and interleukins 1 and 2. And most importantly, you'll get autoreactivity in your T and B cells. So that's known as molecular mimicry, that similarity between the epitopes on the strep group A and our own cells. So once you get that autoreactivity of T cells, you get also T and B cells, you get all sorts of things. You get joint swelling, which is actually, they believe, a product of a physical buildup of these antigen antibody complexes, these immune complexes in the joints. So you're literally reacting with so many of these antigens and with your own antigens via autoreactivity that you get that swelling in your joints. And then you get nodular formation, which is just kind of these bumps under the skin. You get chorea, which is very rare but can happen up to 6 months after infection. And chorea is essentially just unwanted movement and uncontrolled. It's like spasms, and that is generally linked to autoimmune activity, specifically in the basal ganglia, which is really important for your motion. Now, what's important here, and what has the biggest impact on morbidity and mortality is how this can progress into a rheumatic heart disease. And that's about 30 to 45% of cases. So, rheumatic heart disease, if we start and look down here, it starts with that group A strep infection in your pharynx. You get molecular mimicry, you start getting, if you're part of that group, I don't know if I mentioned, it's only about 0.3 to 3% of people that are actually genetically predisposed to have this disease. So if you're part of that group, you'll get this molecular mimicry and you'll actually activate autoreactive T and B cells. From there, those are going to act primarily on tissues of the heart because those tissues of the heart contain proteins that have epitopes that are very similar to that staph group A epitope. So it thinks it's attacking staph group A, it's really attacking you. And what you can get most commonly is you get this autoimmune attack of your valves. So you get some of the myocardium, so you get a general swelling of the heart, but most importantly, you'll get this attack of the valves, and that leads to all sorts of things, ultimately heart failure if it's left uncontrolled. But valvular regurgitation on its own is both a sign of this, but it's also a symptom, and it's really bad on its own because you're getting blood coming back from your atria into your ventricles. It means your heart has to work a lot harder for the same result, and it just is going to lead to worse conditions and worse quality of life. So here's a bit of the actual mechanism of how rheumatic heart disease works. So it starts with you have activation of these autoreactive T and B cells, and you're going to get autoantibodies are going to bind to the epithelial cells on your valves. And the reason they do that is because they recognize and bind to laminin and vimentin, which are the two main proteins that have epitopes similar to the group A staph epitope. So you have group A staph, it has its protein M, and on that protein M, there's an epitope that's really similar to these two epitopes on these two proteins. So if you activate an immune cell that's going to attack that and recognize that, it's also likely going to recognize yourself. So once it binds, you are going to increase the amount of VCMA1, which is vascular cell adhesion protein 1. You're going to increase that number on your epithelial cells, which is going to allow CD4 positive cells to bind to that and move into the avascular matrix inside your valves. And I don't know if my face is blocking this, but in there is where you're going to start mediating a Th1 response. So you're going to start getting, once your CD4 cells are inside the avascular matrix, they're going to start really pumping out interferon gamma, interleukins 2 and 10, and tumor necrotic factor alpha. And then another thing that happens is epitope spreading. And epitope spreading is really kind of bad because you just start, it's designed as part of your immune system to help you start attacking different epitopes that aren't previously recognized, but that you have already attacked, like on a pathogen that you've already attacked. But in this case, because it's autoimmune, you start recognizing other human proteins. So you start recognizing epitopes on stuff like collagen. And again, you just get a spread of damage and a huge increase in it. So now we have prevention and detection. Prevention is actually primarily done via kind of uplifting the economic status of people. That's the best way that we can actually prevent this disease because it's considered a disease of poverty. And the reason is it's, it's kind of a perfect storm to actually get this disease. You have to be genetically predisposed and you have to have that streptococcus infection. And that's much more common in low-income areas where you have poor hygiene, you have household overcrowding is actually a big part of it. So one of the simplest and easiest ways to prevent this is just to essentially try to bring up the economic development of developing countries and areas, even in developed countries, where this is common. As for vaccines, there's no official vaccine out for streptococcus, but there are a couple in development, and there's kind of two main schools of thought and two main directions that people take on this. One is to try to develop a multivalent vaccine, which is essentially just targeting the most common M protein epitopes that actually cause that autoimmune reactivity, which is the rheumatogenic. That means that they're activating autoimmune cells. And then the other one is to target specifically, instead of having a bunch of just the most common M protein epitopes, the other school of thought is, well, there's this conserved C terminal on that M protein, maybe we can just target that. And we don't need a bunch of epitopes. You don't need to develop immunity to that. So those are the two kind of things that are developing. It's really tricky to actually develop a vaccine like this because you're trying to get your body to recognize things which, if it does recognize wrong, is going to create autoimmunity. So really tricky to actually make the vaccine. That's a big reason there hasn't been one yet. As for detection, there's really no like gold standard for this. It's usually just done clinically, and what you can do obviously is you can take a pharyngeal swab, and if you see that group A strep or its antigens in there, there's a possibility. Now that doesn't actually tell you for sure because again, you might just have an infection. It might not develop into rheumatic fever. You can also do antibody tests. But probably more importantly is if you suspect someone to have rheumatic fever, it's really important to do an echocardiograph because in 70 to 90% of people with rheumatic fever, you can detect carditis basically preclinically with this echocardiograph, and that might save the person's life because then you can start treating and preventing what the real killer is, which is rheumatic heart disease, much earlier. So finally, here's treatment. Penicillin is kind of just the general treatment because you can't treat the autoimmune part of it. You generally just go after palliative care and then trying to treat against the actual group A strep. So penicillin is the drug of choice. That's what that little boy is getting injected. They actually do that. It's a shot right in the butt. So they do that. They'll extend it over the course of years if they need to, the amount of treatment you get to try to prevent you ever getting that infection. And then aspirin for mild rheumatic heart disease and ACE inhibitors for the more serious ones because you want to vasodilate essentially to keep your heart pumping, not have it work harder than it needs to. Then interestingly enough, dopamine antagonists because it works on your basal ganglia and reduces chorea. All right, that's it. These are my image credits. I know the video is a bit long, but thanks for watching. Goodbye.